on the involvement of the hair follicle into follicular and non-follicular pyodermas. So under follicular pyodermas, the most important organism to remember here is Staphylococcus aureus. There are three important hair follicle infections to remember. Number one is folliculitis, number two is furuncle, number three is carbuncle. First, let's take up folliculitis. Now, folliculitis is defined as hair follicle infection. So, hair follicle infection is referred to as folliculitis. How is the patient going to present here? You get a follicle-oriented pustule. So, what do I mean by follicle-oriented pustule? This pustule is going to be around or centered around the hair follicle. So, if you see a hair strand coming out of the pustule, that means it's a hair follicle-oriented pustule. Next condition is furuncle. Now, what is the definition of furuncle? Furuncle involves hair follicle and perifollicular area. Hair follicle and perifollicular area is called as furuncle. So the patient is going to present with a red indurated tender nodule. So it's a deeper infection of the skin, but involves the hair follicle, and this is called as a furuncle. In common terms, we also call it as a polyp. Lastly, the most severe form of follicular pyodermas is going to be carbuncle. Now carbuncle is going to involve multiple hair follicles plus contiguous areas. What is the meaning of the word contiguous? Contiguous means the adjacent areas. Now, how is the patient going to present? You get a red indurated tender nodule. This is point number one. Point number two, you get multiple pustules on the surface. The most common site of a carbuncle is nape of the neck. And the most important association of a carbuncle is going to be diabetes mellitus. To summarize this topic, folliculitis involves hair follicle. Furuncle involves hair follicle plus the perifollicular area. Carbuncle is going to involve multiple hair follicles plus contiguous area. Let us now move to the classification of non-follicular pyodermas, which are divided into localized and spreading infections. Under localized, superficially we have impetigo. The deeper form is called ecthyma. In spreading infections, we have erysipelas is superficial, cellulitis is deeper. Please keep this classification in mind because I see a lot of students who do not know the difference between erysipelas and cellulitis. Always remember that erysipelas is superficial and cellulitis is deeper. Now we go to the definition of impetigo. Impetigo is defined as bacterial infection of the epidermis. Bacterial infection of the epidermis. We classify impetigo into non-bullous and bullous variants. Non-bullous impetigo is also known as impetigo contagiosa. Let us look at the clinical features over here. Now, non-bullous impetigo is produced by both Staph aureus as well as group A streptococci. It is usually seen in a child. The site is going to be on the face and mainly concentrated around the perinasal and perioral areas. The characteristic crust which you get here is called golden brown honey color crust. So, if you see a golden brown honey color crust in a child, perinasal, perioral is very typical of a non-bullous impetigo. We want bullous impetigo, which is exclusively produced by Staphylococcus aureus. Please make a note of this, students, because most of you, what happens is you read generally, and what happens, you know it is strepto or staph, you can't remember which one. That is why it's very important to learn the purpose. Keep this in mind. Staphylococcus aureus is the exclusive organism for bullous impetigo. Now, what kind of lesions you're going to get? You're going to get bullae, and this bullae are going to rupture, and they're going to leave behind something known as varnish crust. Varnish is something which you apply as paint to the wall, so that's called as varnish. The site is going to be usually on the trunk of the patient. Let us look at some. Common topical antibacterials that we should know once we have passed out Mbbs. Number one is fusidic acid. Number two is mupirocin.
Hello.
So these are three important topical antibacterials. Please do note that mupirocin and ozinoxacin have got action against the superbug methicillin-resistant Staphylococcus aureus. We now move to the spreading infection. This is more of surgical topic. Erysipelas and cellulitis. Now, erysipelas is exclusively produced by
topical antibacterial fusidic acid,
Let us look at some common topical antibacterials that we should know once we have passed out Mbbs. Number one is fusidic acid. Number two is mupirocin. And number three is ozinoxacin. So these are three important topical antibacterials. Please do note that mupirocin and ozinoxacin have got action against the superbug methicillin-resistant Staphylococcus aureus. We now move to the spreading infections. This is more of surgical topic. Erysipelas and cellulitis. Now, erysipelas is exclusively produced by group A streptococci. So please make a note, everybody, that group A streptococci exclusively produces erysipelas. Now here, the level is going to be the upper half of the dermis plus lymphatic compartment gets involved. So once you have the upper half of the dermis plus lymphatic compartment gets involved, the spreading infection is called erysipelas, and the margin of this lesion is well demarcated and raised. Because the upper half of the dermis is a tight compartment, the infection gets very beautifully restricted. It's well demarcated and raised margins which you get. So well demarcated raised margin, usually common in the lower limbs. Whereas when we talk about cellulitis, cellulitis can be produced by both group A streptococci as well as Staph aureus. And the level is going to be just below this lower half of the dermis plus subcutaneous tissue. Once the infection goes into the subcutaneous tissue compartment, what happens? It tends to spread. That is why the margin of this lesion is going to be ill-demarcated, diffuse margins. If it is mentioned in the exam, mark your answer as cellulitis. We want this very, very interesting topic of Staphylococcus scarlet skin syndrome. So when you look at the word scald, what is the meaning of scald? Scald is
wet
like
burn.
a burn. And you know what happens in a burn? There's going to be
Exfoliation
of the skin. So there's exfoliation of the skin. So what is Staphylococcus scarlet skin syndrome? It is an acute skin exfoliation which is induced by toxin-producing strains of Staphylococcus aureus. So not all the strains, only the ones which can produce a toxin is going to mediate this SSSS. Let us now look at the pathogenesis of this very interesting condition. In this condition, what happens is there is a focus of
exotoxin, distance, source of infection, diffuse through blood and skin, desmoglin. Okay, तो
which is induced by toxin-producing strains of Staphylococcus aureus. So not all the strains, only the ones which can produce a toxin is going to mediate this SSSS. Let us now look at the pathogenesis of this very interesting condition. In this condition, what happens is there is a focus of infection of Staph aureus, which could be either in the ear or it could be in the conjunctiva. So here what happens is Staphylococcus aureus is going to produce exotoxin. We know that Staph aureus is a gram-positive organism. It produces exotoxins. This exotoxin is called epidermolytic toxin. That means it will lyse the epidermis. But the question is, the organism is in the ear or in the conjunctiva. How is it going to reach the skin? The toxin which is produced is going to move hematogenously. So via blood, it diffuses and then reaches the skin. And once it reaches the skin, what will happen to this toxin? It is going to target a particular protein, that is the desmosomes. And we already know in bullous disorders that desmosomes are made up of two important
desmoglin 1 and desmoglin 3.
Desmoglin number 3. So please remember, this epidermolytic toxin is going to be targeting desmoglin number 1. And once desmoglin number 1 gets targeted, we know that you're going to get a subcorneal split. Because desmoglin 1 is mainly expressed in the upper epidermis, just below stratocorneum. The process by which desmosomes get ruptured is referred to as acantholysis. Is referred to as acantholysis. Now, how is the patient present? The toxin is diffused in the blood, means automatically constitutional symptoms like fever will be present. And then what's going to happen is severe skin tenderness is going to be there, and then after some time what will happen? Staphylococcal scarred skin syndrome. Scarred means the peeling of the skin. You can notice here there is sheet-like epidermal peeling. Very, very important point, sheet-like epidermal peeling. And then what you want to do is, with the sheet-like epidermal peeling, you take your thumb and put tangential pressure on the skin. What's going to happen is you get a sign positive, which is called as true Nikolsky sign. So there are two types of Nikolsky, true and pseudo. So true Nikolsky sign is going to happen due to acantholysis. So because of the acantholysis which is happening here, true Nikolsky sign will be positive. The upper layers of the epidermis start sliding below the lower layers of the skin, resulting in a positive sign. But please remember, students, I've already told you that desmoglin number 1 is expressed in low concentration within the oral cavity. That is why, since this condition is targeting desmoglin 1, there are no oral lesions. Mucosa is going to be normal. That is how you understand how to distinguish staphylococcal scarlet skin syndrome versus TN. In TN, mucosa is always involved. Mucosa is strongly involved in toxic epidermal necrolysis. We move on to the next condition of acute paranoia. Now, acute paranoia means infection of the nail fold. The acute nail fold infection is called paranoia. The organism which is implicated in Staphylococcus aureus. And here you can see there is erythema, a collection of pus. You can see the nail folds. The treatment of this condition is anti-staphylococcal antibiotics. Anti-staphylococcal antibiotics. And if there's a frank pus, you may have to do incision and drainage. Incision and drainage, there is frank pus. Next, we move on to the cutaneous corneal infections. Number 1 is erythrasma. Number 2 is trichomycosis axillaris. Number 3, pigment keratolysis. Let's take up the first one, which is erythrasma. Now, erythrasma is produced by an organism, Corynebacterium minutissimum. So please keep this in mind, everybody. Very, very important organism. How does the patient of erythrasma present? Erythrasma presents with asymptomatic reddish brown hyperpigmentation. So right now, asymptomatic reddish brown hyperpigmentation. The word eryth means red. That's why you have red here. Because these reddish brown hyperpigmentation sites are usually on the axilla and the groin. These are two important sites. Then you want to do a Woods lamp examination. You get a characteristic color, which is called as coral red fluorescence. This color is given the name of coral red fluorescence. Next condition is trichomycosis axillaris. Now, trichomycosis axillaris, please remember, though the word says mycosis, this is not a fungal infection. That means it's actually a bacterial infection. So please remember, it is a misnomer. Whenever trichomycosis comes in the exam, forget the mycosis. Think about the letter T. This organism is produced by Corynebacterium tenuis. So T for tenuis, T for trichomycosis. How does the patient present? You have the axillary hair, which has yellow color concretion. So yellow color concretions over the axillary hair shafts. That's a classical presentation of Corynebacterium tenuis. The last condition in corneal infections is pigment keratolysis, which is produced by Micrococcus, also known as Chytococcus sedentaris. Now, how is the patient going to present? It's a very easy topic. Please read this topic in the reverse direction. Lysis of keratin results in pits. That means this organism is going to lyse the keratin, which is there on the palms and the soles, and it is going to result in pits. So you get multiple depressions, punctate depressions on the palms and soles. This is a classical presentation of pigment keratolysis. Next, we move on to Pseudomonas infections. Number 1 is ecthyma gangrenosum. Now, ecthyma gangrenosum is usually seen in patients of sepsis or septicemia. Septicemia is the association of ecthyma gangrenosum. Number 2, you have hot tub folliculitis. Hot tub folliculitis is usually seen in patients who are taking bath in an ill-maintained spa. And lastly, we have green nail syndrome, which happens because of Pseudomonas infection. This is because the pigment which is produced by Pseudomonas aeruginosa. Next, we go to meningococcemia. Now, meningococcemia is going to be produced by Neisseria meningitis. How am I going to suspect this condition? The patient is going to present with fever and signs of meningitis. Like, you're going to have neck rigidity. And what cutaneous lesions are you going to expect here? You can see these red color lesions over here. If you remember, I have already told you this point in basics in dermatology. Whenever there's a red lesion, take a glass cat and press. And if there's a non-blanching response, you know you're dealing with purpura. So the patient is going to present with a petechial rash. So exam, if there is a situation where there's a patient with fever and signs of meningitis and a petechial rash, our diagnosis is going towards meningococcal meningitis. We move on to the next topic of cutaneous anthrax. So please remember, students, cutaneous anthrax is produced by Bacillus anthracis, which is a gram-positive organism, and this is usually seen in individuals who are having history of contact with animal products. So after contact with these animal products, what is going to happen? You're going to get a classical lesion here. So in cutaneous anthrax, what do we see? We see there is a central ulcer which is covered with a black scab and surrounded by a lot of edema. So if there's going to be the presence of a central ulcer with a black scab surrounded by profound edema, you're dealing with a lesion called as malignant pustule. Malignant pustule. So please remember, students, malignant pustule is also a misnomer. So it is considered as a misnomer because it is neither malignant nor it is a pustule. It is basically a black scab which is overlying an ulcer surrounded by a lot of edema. We now move on to this interesting topic of scrub typhus. Now, scrub typhus is a rickettsial disease. It is produced by Orientia tsutsugamushi. The vector has been asked in a recent exam. It's going to be by thrombiculate mite. The clinical features is going to be
tsutsugamushi
and some CNS symptoms. And then you're looking at this lesion over here. You see a black scab which is surrounded by erythema. This lesion is called as an eschar. So eschar is a black scab surrounded by erythema. Black scab surrounded by erythema. The treatment of choice for scrub typhus is going to be doxycycline. Next, we move on to cutaneous tuberculosis. And the cutaneous tuberculosis number 1, we have a condition called TBVC. Tuberculosis verrucosa cutis. Please remember, students, wherever the word verrucosa comes, anywhere in dermatology, it means anything in dermatology with a rough, uneven, or a warty surface. So anything in dermatology with a rough, uneven, or a warty surface, we think of TBVC. Tuberculosis verrucosa cutis is also referred to as anatomist's wart. As we've already learned the meaning of the word verrucosa, you can see this indurated. Indurated means hard. Verrucous plaque. Indurated verrucous plaque, which is predominantly distributed over the extremities. It is more commonly seen in individuals who handle dead bodies, like anatomists and from the Department of Forensic Medicine. Next, we move to lupus vulgaris. What is the meaning of the word vulgaris? Vulgaris means this is the most common cutaneous tuberculosis in adult. The most common form of cutaneous tuberculosis in adult is lupus vulgaris. How is the patient going to present over here? The lesion is going to be a plaque lesion. You can see that there is center shows atrophy plus scarring. Center shows atrophy plus scarring. And if you look at the periphery, periphery shows extension. Periphery shows extension. And site is going to be on the face, buttocks, and extremities. So always remember, you're going to have a plaque. Center shows atrophy plus scarring. Periphery shows extension. And lesion is going to be on the face, buttocks, or extremities. What you want to do is you want to perform a test called as diascopy. Now, during diascopy, what you want to do, you take a glass slide and press the lesions of lupus vulgaris. You can see this lesion before pressing, and after pressing the lesion, you can see what has happened over here. You're going to get this characteristic color. This is a yellow-brown color. It means that there are dermal granulomas, and this is called as apple jelly nodules. So this is a very characteristic feature of apple jelly nodules, but can be seen in any dermal granulomatous disorders. We now move to the last form of cutaneous tuberculosis, which is called scrophulodderma. Please remember, students, that scrophulodderma is the most common cutaneous TB in a child. So what is the disease here? There is direct invasion of M. tuberculosis into the skin. So what happens is the root here is endogenous. That means there should be some focus of infection of tuberculosis, which is endogenous. That means this focus could be anywhere. It could be a lymph node, it could be bone, it could be facial. So from here, the mycobacterium tuberculosis is directly going to invade the skin. And out of all these foci, the most common one is the cervical lymph nodes. Very, very important. So here we can see how does the patient present. So you see multiple painless subcutaneous nodules. So you can see painless subcutaneous nodules. This is point number 1. Point number 2 is you get discharging sinuses. Disease opens into the skin. You get discharging sinuses. You get ulcers with undermined edges and fibrotic scars. So discharging sinuses, ulcers with undermined edges, and fibrotic scars. So this is going to be the classical presentation. So you can see the multiple lesions which have healed with a lot of scarring in a child. On the sides of the neck is pointing towards scrophulodderma. Let's start discussing fungal infections of the skin. So first we are going to have pityriasis versicolor. Now pityriasis versicolor is produced by Malassezia globosa followed by furfur. So please make a note that globosa is more commoner than furfur. Now if you split the word, pityriasis means scaling. Versicolor means variety of colors. If we look at the scales of pityriasis versicolor, there are 3 important words to remember. Fine, brany, furfuraceous scales. So 3 important keywords for the scales in pityriasis versicolor are fine, brany, furfuraceous scales. In terms of the color, we have 2 presentations. Number 1, the hypopigmented macules. This is the more commoner presentation. We can also get hyperpigmented lesions. So both hypo and hyper are possible. Hypo is more common. Look at the site. It's going to be generally on the trunk of 2 presentations. Look at the scales of pityriasis versicolor. There are 3 important words to remember. Fine, brany, furfuraceous scales. So 3 important keywords for the scales in pityriasis versicolor are fine, brany, furfuraceous scales. In terms of the color, we have 2 presentations. Number 1, the hypopigmented macules. This is the more commoner presentation. We can also get hyperpigmented lesions. So both hypo and hyper are possible. Hypo is more common. Look at the site. It's going to be generally on the trunk. And in terms of investigation, we want to do a 10% potassium hydroxide mount. We're looking for short hyphae and round spores. The short hyphae, which are there, you can see some short hyphae and round spores. The short hyphae is compared to spaghetti. And the round spores are compared to meatballs. That's why it is called spaghetti and meatball appearance. The treatment of bitters vesicular in first line is going to be topical azoles. You can also do selenium sulfide. Systemic drug that usually uses fluconazole. Next we move to candidiasis. Now candidiasis, talking about oral candidiasis, is also referred to as oral thrush. Also referred to as oral thrush. So the color of the lesion is going to be white. You get white pseudomembranous plaques. But please remember these pseudomembranous plaques can be rubbed off. Please make a note that these white pseudomembranous plaques can be rubbed off because it's a pseudomembrane, you can't remove it. And candidiasis, please remember students can also present with red plaques because most of us think it is only white, it can be red also. This candidiasis is called atrophic candidiasis. This form of candidiasis which presents with red plaques is called atrophic candidiasis. Then there is a question previously in the exam, what is candidiasis involving the intertriginous areas called? It's called intertrigo. So candidiasis involving the intertriginous areas means basically the folds is referred to as candidial intertrigo. How is the patient present? You can see a red macerated plaque. So this is a red macerated plaque. So what is the meaning of the word maceration? Maceration means soft to wet. You palpate. So when you touch, if you feel the lesion is soft to wet, then you consider that as maceration. And if you see in the periphery, few lesions here and there, you can find some lesions which are called as satellite pustules. See lesions which are called as satellite pustules. Next we move to candidal palmoposteitis. So this is going to be candidiasis which involves the glans penis and the prepuce. And what is it characterized by? You're going to get the presence of this radial fissuring. So you get radial fissuring. You get multiple cuts around the glans penis, and this is again associated with diabetes mellitus. This is associated with diabetes mellitus. Next we move to treatment of candidiasis, which is going to be mainly fluconazole. We move to the next important infection.
Pityriasis versicolor, Melasthesia globus, hypopigmented macules, fine brainy furfuraceous scales, spaghetti meatball, topical azole, selenium sulfide, systemic fluconazole. Candidiasis, oral thrush, white pseudomembranous plaque, can be rubbed off. Candidiasis is red plaque, atrophic candidiasis, candidial intertrigo, intertriginous area, skinful. Candidial melanoprosteitis on glans. Treatment is fluconazole. Candidiasis treatment is fluconazole.
It's going to be dermatophytosis. Now, dermatophytosis, please remember, is also referred to as tinea. Also referred to as tinea. Now, let us go region-wise. Now, what is tinea capitis? Tinea capitis is dermatophytosis
Capitis.
of the scalp hair.
Corporis. Corpora means body. Crura means groin.
We have number one, black dot. Number two is grey patch. And inflammatory, pavus and kelia. Let us now see the clinical manifestations of this condition. So, non-inflammatory, the first one I told you is going to present with child who has patchy alopecia. There are multiple broken hairs at the level of the scalp. So if you get broken hairs at the level of the scalp, we're talking about an endothrix infection. This is called as a black dot. And what is the causative organism of this endothrix? T and V, you can remember. Trichophyton tonsurens.
Tonsurens violatium.
Which is endothrix. Now, yet another situation, there is a child with patchy alopecia. But with patchy alopecia, what is mentioned here? With greyish scaly lesions. So if you're talking about grey scaly lesions, you're talking about ectothrix. So this is called grey patch type. The etiology for this condition is Microsporum species, especially Microsporum cats. Talking about inflammatory tinea capitis, number one, the first scenario is a child from Kashmir presenting with this yellow color cup-shaped lesions. If you get these yellow color cup-shaped crusts over the scalp, this is referred to as scutula. And the condition where you get scutula is pavus. So, the mechanism of pavus? Yes, it is Trichophyton schonlani. So remember, I've already told you in the examination, this gives a dull blue color on wood slab. Next, we move to the last form, the most important form of inflammatory tinea capitis. So here the question comes in the exam like this: is a child with history of contact with a pet animal, a dog, and then let's see a boggy scalp swelling, easily pluckable hair, regional lymph nodes are enlarged. So child, boggy scalp swelling, easily pluckable hair, regional lymph nodes if they are enlarged, our diagnosis is going to be helium. This is also a type of inflammatory tinea capitis. Two important organisms are there. Number one, Trichophyton mentacrophytes, Trichophyton verrucosum. So please remember, students, that these two fungi are referred to as zoophilic fungi. So zoophilic fungi are fungi which are usually going to be associated with animals. Accidentally, they come in contact with human beings and produce a lot of inflammation. Next, we look at dermatophytosis in the groin, which is referred to as tinea crurus. Tinea crurus is also referred to as jock itch, also referred to as thobi itch. So this is a plaque of tinea where you can see the prominent border.
Crura.
Border with central
Jock itch, thobi itch.
This patient of tinea crurus. Now, dermatophytosis is the feet. This is also referred to as tinea pedis. Tinea pedis is also referred to as athlete's foot. And please remember, students, the most common toe web space is going to be the fourth toe web space, because in the fourth toe web space we see that the gap is lesser, and whenever the gap between the toes is lesser, the chance of fungal infection increases. Next we move on to onychomycosis. Now onychomycosis is nothing but fungal infection of the nail. So if you look at the nail plate over here, if you see the color of the nail plate is going to be yellow, and let's see below the nail, there are two things. Number one, you can see hyperkeratosis, and within that area you can also see a lot of tunnels. So you can see tunneling here. Multiple tunnels are seen within the subungual hyperkeratotic areas, and pits are absent in this condition. For onychomycosis, please remember, pitting is not a feature of onychomycosis. The most common type of onychomycosis is the DLSO1, where it involves distal and lateral. So this is called as distal lateral subungual onychomycosis. This is a patient. Let us now take up this previous question where nail lacquer usage in onychomycosis was asked. So three important drugs which are available as nail lacquer. Number one, amorolfine 5%. Number two is cyclopyroxycholine 8%. Number three is terbinafine. So apart from this, none of the drugs are available as nail lacquers. Next we go to the morphology of tinea corporis. So when I say tinea corporis, the regular tinea that we get, two important organisms are there, Trichophyton mentagrophytes and Trichophyton rubrum. Now how does the patient of tinea present? So you are going to have an annular plaque, central clearing, peripheral raised scaly margin associated with itch. So annular plaque, central clearing, peripheral raised scaly margin associated with itch. This is going to be the clinical features of tinea corporis or brutus. And what is tinea incognito? Many times in India, we do not know what to do, don't want to show dermatologist or dermatologist is not available. What people do is they go to the pharmacy and generally the pharmacists give them steroid technique preparations. So steroid modified tinea. It's called tinea incognito. So here what happens due to this tinea incognito, most of the MBBS students cannot identify tinea, because you can see this is one of the patients with extensive tinea, but you're not able to identify it because there is no annular plaque, there is no central clearing, this diffuse scaling which is going to be present. So this is a tinea incognito. The treatment of this condition is number one, you give azole group of drugs, you classify them into imidazoles and triazoles. In imidazoles you have ketoconazole, fluconazole, and clotrimazole. In triazoles is fluconazole and itraconazole. These are the two important drugs to remember. In allylamines we are obviously going to go for terbinafine. So this is a good drug which is available, terbinafine. But one thing you need to remember, terbinafine resistance is increasing. The enzyme which is involved in terbinafine resistance is squalene epoxidase. Squalene epoxidase. So squalene epoxidase is the enzyme which is involved in terbinafine resistance. One more important question, please remember students that there is an epidemic of severe recalcitrant tinea. So this is happening due to multiple reasons. In terms of the organism which is forming an epidemic across the Indian subcontinent for recalcitrant severe dermatophytosis is called Trichophyton indotinea. So please make a note, Trichophyton indotinea is responsible for the epidemic. Formerly this was classified as Trichophyton mentagrophytes, genotype number 8. So formerly called Trichophyton mentagrophytes, genotype number 8. Now this condition is going to be named as Trichophyton indotinea. Next, moving on to subcutaneous mycosis, also known as implantation mycosis. Now, implantation mycosis means the fungus has to come from outside. This traumatic inoculation of the fungus. Traumatic inoculation of the fungus. There are three important types of subcutaneous mycosis. Number one, sporotrichosis. Number two, chromoblastomycosis. Number three, mycetoma. Taking up the first one, which is sporotrichosis. Sporotrichosis is produced by Sporothrix shankai. This organism is an example for a dimorphic fungi. It's a dimorphic fungi. Also referred to as rose gardener's disease. Now, what is the history going to be here? The history is going to be a gardener with history of thornprick. Gardener with history of thornprick is going to be the history. And after the thornprick, what happens? Thornprick, you're going to have a nodular ulcerative lesion. After the nodular ulcerative lesion, you get linear lesions. You get a linear pattern of lesions. Linear pattern of lesions along the lymphatics of the extremity. Along the lymphatics of the extremity. So please remember, students, gardener with history of thornprick, after that nodulo-ulcerative lesions, after that this linear pattern of lesions along the lymphatics of the extremity. That is because this organism is going to target the lymphatics of the extremity. That's why lymphatics run linearly. That's why you get linear pattern of lesions. Let's look at the differentials of a sporotrichoid skin lesion. That means skin lesions which resemble sporotrichosis. Number one, we have nocardiosis. Number two, atypical mycobacterial infections. So here we're talking about swimming pool, also known as fish tank granuloma. Number three, leishmaniasis. Number four is tularemia. So four important differentials here are nocardiosis, atypical mycobacterial infections like swimming pool granuloma, cutaneous leishmaniasis, and tularemia. So this is important. Please remember that swimming pool granuloma is produced by Mycobacterium marinum. So from the word marinum, you can remember swimming, you can remember fish tank. Now we go to the histopathology. Here we have the asteroid body, which is a very characteristic depiction of the histopathology. You have this central basophilic yeast, radiating eosinophilic material. Central basophilic yeast and radiating eosinophilic material. What is the treatment for sporotrichosis? It is itraconazole. The second subcutaneous mycosis is chromoblastomycosis. Now, what is the meaning of the word chromo? Chromo means color. Pigmented fungi in microbiology are referred to as hematiaceous fungi. What does it mean? It means these organisms have melanin in their cell wall. That is why we have colored or pigmented fungi. There are two important species to remember. Number one is Sarsia petrosoi. Number two is Phyllophora verrucosa. So these are two examples of pigmented fungi. Now, please remember that chromoblastomycosis is also referred to as verrucous dermatitis. discussed earlier, anything in dermatology which has a rough, uneven, or warty surface, we call it as verrucous. What will be the history here? It's usually a farmer with history of vegetative trauma. Farmer with history of vegetative trauma, because this fungus is there in soil and decaying matter. If you look at the skin lesions, you can see a verrucous plaque. You can see a plaque with a rough surface, and on the surface, if you carefully see, you can see some black color dots. Black color dots on the surface of the lesion. But verrucous indurated hard plaque with a rough surface is more important. And then you can see these cauliflower-like lesions. These are called as cauliflower-like lesions. So two important presentations. Number one, you have the verrucous plaque kind of presentation. Number two, you have cauliflower-like lesions. What investigation you want to do? You want to do a 10% potassium hydroxide mount from these scales. And what are you looking for? You can see these very beautiful structures. I see them as brown thick-walled bodies.
copper
So the shade
pen.
is brown, round, thick-walled bodies.
Chromoblast
Melanin,
necrosis and
which is there in
copper
the cell
pen.
wall of the organism. And these bodies are referred to as medlar bodies, sclerotic bodies, copper-penny bodies. So medlar, sclerotic, and copper-penny bodies are the other names for these brown, round, thick-walled bodies. Treatment of this condition is intracorneal. Moving on to mycetoma. Now, mycetoma is a chronic granulomatous condition. It's a fungal infection. It can be classified based on the etiology. Is it produced by fungi or bacteria? If it is produced by fungi, we call it as a eumycetoma. If it is produced by bacteria, we call it as actinomycetoma. So eumycetoma and actinomycetoma. And eumycetoma is produced by Madurella species, that is Madurella
Mycetomatis.
and Madurella grisea. Actinomycetoma is basically produced by aerobic filamentous bacteria. Aerobic filamentous bacteria. Three important organisms to remember here are: number one, Actinomadura madure, Nocardia species, and Streptomyces species. So Actinomadura madure, Nocardia species, and Streptomyces species. These are three important species we need to remember. Now, what is the triad of mycetoma? Point number one, you get huge swelling. This is called tumefaction. It means tumor-like swelling. Number two, we have discharging sinuses. Number three, from the sinuses, you're going to get the presence of granules. What are these granules? These are colonies of the microbe. But please remember, students, if the color of the granule is black, the examiner is talking about eumycetoma. So please remember this point. If there are black or dark color granules, always mark it as eumycetoma. You see some more pictures of mycetoma. You can see some nodular lesions with tumefaction. Here you see some healed sinuses on the feet with some nodular lesions. So tumefaction, sinus formation, discharging granules, prior of mycetoma. What is it? We have to give antibacterials. We use something known as Welch regimen. Welch regimen is made up of two drugs. Number one is made up of cotrimoxazole. Number two is made up of amic acid. So this is the combination that we use. For eumycetoma, we give antifungals. Let's begin with the next topic on viral infections. First, we have oral-label herpes, which is produced by HSV1. This condition is also referred to as fever blister, also referred to as cold sore. It is usually because HSV1 reactivation happens during an episode of fever or during an episode of upper respiratory tract infections. So how does the patient present? You have vesicles is point number one, grouping is point number two, lip margin is point number three. So if you have grouped vesicles on the lip margin, these 3 points are enough to make a diagnosis of oral-label herpes. The treatment of this condition is tablet acyclovir, 400 mg thrice daily for 5 days. So this is the drug that we give in oral-label herpes. Next, we move to varicella. Varicella is also referred to as chickenpox. Is produced by varicella zoster virus. The period of infectivity is till all the lesions are crusted or have formed a scab. And the skin lesions are a typical vesicle on a red base. So this is compared to dewdrop on rose petal appearance. So dewdrop on rose petal appearance is this vesicles on red base, very characteristic feature which every MBBS student should know. And usually varicella lesions are first seen on the trunk. So that's one more thing to remember. And what is unique about varicella is various stages of the lesions like macule, papule, vesicle, pustule, scab. All these lesions are present simultaneously. This feature is referred to as
Pleomorphic.
So when I say pleomorphic rash means different lesions are present at the same time. Because varicella comes as crops. You can see a pustule, you can see a few erythematous macules, you can see some vesicles, custard lesions. So all kind of lesions at the same time is present as pleomorphic. Herpes zoster is also referred to as shingles. This is characterized by reactivation of the varicella zoster virus from the dorsal root ganglion. So that is important. Now this was a question which was asked in this is NEET PG exam. There is one drug which is used in management of multiple myeloma, which is associated with herpes zoster infection. That is called
Borte.
Now bortezomib is a proteasome inhibitor. It's a proteasome inhibitor. One of the characteristic side effects of this drug is development of herpes zoster. Now, there are 3 important features to diagnose herpes zoster. Point number 1, it is unilateral. Point number 2, it is dermatomal. Point number 3, it is characterized by grouped vesicles on a red base. So, please remember the 3 important points for herpes zoster. Point number 1, it's unilateral. Point number 2, it's dermatomal. In dermatomal, please remember the most common dermatome involved is the thoracic dermatome. And it is characterized by painful grouped vesicles on red base. So, these are the 3 features. Now, after herpes zoster has resolved, what the patient might land up is post-herpetic neuralgia. So please remember, post-herpetic neuralgia is from the complications due to the nerve damage which happens, and the characteristic symptom of this is allodynia. Allodynia is a symptom wherein a non-painful stimulus is perceived as painful. If a non-painful stimulus is perceived by the patient as painful, you touch the patient but the patient is feeling pain, then think of allodynia as a manifestation of post-herpetic neuralgia. If you move on to the treatment of herpes zoster, we have 2 options: acyclovir or valacyclovir. Acyclovir is 5 times daily, the dosage of 800 mg for 7 days. Valacyclovir is just 1 gram TID for 7 days. So this drug has better bioavailability. So that is why this drug is given just thrice a day. But please remember, treatment of both varicella as well as herpes zoster remains the same. So one of the two options we can give. We want the next viral infection called as oral hairy leukoplakia, which is produced by Epstein-Barr virus. EBV is Epstein-Barr virus. And how does the patient present here? So patient is going to be an HIV infected patient, presents with a white corrugated plaque. Now what is the meaning of the word corrugated? Corrugated means thrown into folds or ridges. What is the site of this lesion? Lateral border of the tongue. Point number 4, cannot be rubbed off. So in the context of HIV, if the patient is having a white plaque which can be rubbed off, you can mark it as candidiasis. If it cannot be rubbed off and located on the lateral border of the tongue and has a corrugation, you mark it as oral hairy leukoplakia. Next, we move to Kaposi sarcoma, which is produced by HHV8. If you look at the color of the lesion, you can see these purplish lesions. Patient presents with purplish plaques and nodules. What is important is Kaposi sarcoma is an AIDS-defining illness, and though it is a vascular tumor, it is going to be a low-grade tumor. So keep this in mind. It's a low-grade vascular tumor. We move on to the next viral infection called as molluscum contagiosum. This is a benign viral infection of the skin, which is produced by pox virus, which is a DNA virus. Now, there are two important specific viruses for molluscum contagiosum. It is MCV1, which is more commonly in children. Molluscum contagiosum virus number 1, and MCV2 is more commonly seen in adults. In children, if you look at the lesion, the morphology is going to be pearly white, dome-shaped. Center shows umbilication. So centrally umbilicated pattern. That's the characteristic lesion of molluscum contagiosum. So some more pictures to show the facial involvement. One important phenomena over here is pseudococcus phenomena. That means pseudococcus phenomena is referring to the auto-inoculation. That means there is one molluscum on the child. What does the child do? It manipulates it. So what happens when you manipulate it? There is transfer of the virus into the surrounding skin. So from here it becomes 2, it becomes 3. It means along the line of trauma, because of auto-inoculation, if you get new molluscum contagiosum lesions, this phenomena is called as pseudococcus phenomenon. In sexually active adults, anogenital region is commonly involved. This is the anogenital region. Next, more investigations. There are two important features on histopathology. Number 1, you have a cup-shaped invagination. As you can see here, the cup is here. So you have the cup-shaped invagination of the epidermis into the dermis. So this is the cup-shaped invagination of the epidermis into the dermis. So this is point number 1. And point number 2 is you get these pinkish colored bodies. They are eosinophilic intracytoplasmic bodies. They are called as Henderson-Patterson bodies. These are called as Henderson-Patterson bodies. Treatment, number 1, is self-limiting, but go for its own. Number 2, you can physically remove it by a method called as curettage. Curettage can be done. You can remove this by a needling procedure. And lastly, you can use drugs in the form of imiquimod. Now, imiquimod is an immune response modifier. It's an immune response modifier or immunomodulator. IMOD. It acts by stimulating TLR7. So it's a toll-like receptor number 7 agonist. It stimulates the toll-like receptors. Now this question has been asked in the exam. If it comes in the exam, molluscum contagiosum like lesions are there in an HIV patient, but it is restricted to the skin. There's only skin involvement, then we're going to mark it as disseminated molluscum. If the question comes in the exam, there is skin involvement plus lung involvement is there. So there are molluscum-like lesions on the skin, but there is some lung involvement as well. Then you mark it as disseminated histoplasmosis, which is a lung disease. And if molluscum contagiosum-like lesions on the skin are associated with brain involvement or meningitis as a feature, then we are going to mark it as disseminated cryptococcosis. So this was one of the questions in the examination. We move on to the next viral infection, which is Verruca vulgaris. Verruca vulgaris is an HPV disease, human papillomavirus. But please remember the strains 2427. It is not 611, 1680. So please make a note. It is 2427 for the common warts. So common warts are skin warts. They are not genital warts. So please keep this number in your mind. And number 2, we have the clinical presentation. You have asymptomatic, well circumscribed verrucous papules and plaques. Well circumscribed verrucous papules and plaques. How do we treat this condition? Is topically we can go for a keratolytic like salicylic acid. So this drug is going to act as a keratolytic agent. It removes the keratin which is there. Physically we can remove it by electrocautery. You can also use cryotherapy. So these are two modalities that we can use here. Next, we move on to hand, foot, mouth disease, which is produced by Coxsackie A16 enterovirus number 71. Very important to note that the rash is going to be vesicular. So there are very few diseases with vesicular rashes, like the HSV1, then HSV2, then varicella zoster virus in the herpes group, and here we have hand, foot, mouth disease. And the lesions are going to be distributed over the palms and soles. So here we can see these oval vesicles, which are predominantly distributed over the palms and soles. So initially they are macular lesions, then they become vesicular lesions as a very classical presentation of hand, foot, mouth disease. We move on to the next topic of parvovirus B19 diseases. First, we need to remember that parvovirus B19 is a DNA virus. So this is point number 1 from microbiology point of view. It produces a condition called fifth disease, also known as erythema infectiosum. The rash involves the malar areas, erythema over the malar areas, and this is called slapped cheek appearance. This is called slapped cheek appearance. And on the trunk, you can get a network-like rash, which is a reticulate rash. This is the net-like rash. One more important disease which can be produced by parvovirus B19, which has been asked in the exam, is characterized by the development of a symmetrical, painful erythema and petechiae and purpura with a sharply demarcated border involving the palms and soles. This condition is known as PPGS, that is papular purpuric glove and sock syndrome. So this is associated again with parvovirus number B19. Let's move on to the next topic of ectoparasitic infections. We have two important diseases here, scabies and pediculosis. Now scabies is produced by the itch mite, which is Sarcoptes scabi var hominis. So this is point number one. Point number two is the number of mites per patient is going to be 10 to 12. Now history, we have to ask 2 points, nocturnal pruritus, because the mite becomes active in the night. And second point is history of similar complaints in family members and contacts. Now when we examine the patient, scabies is a very itchy condition. You get a lot of excoriated papules. So a lot of excoriated papules are seen in the web spaces of this child, and special lesion of scabies is called as a burrow. So here we can observe the presence of a burrow, which is a serpiginous